So, hi everyone. My name is Mohammed Fouda. I'm a postdoc fellow in the Department of Neurosurgery here at Weill Cornell, and I'm happy to talk to you today about the craniofacial distraction system that we have. So, just a brief introduction about our team. Beside myself, we have Dr. Caitlin Hoffman, who's one of few neurosurgeons in the country who's like an expert in craniofacial abnormalities and cranial distraction. And also, she's deeply involved in global neurosurgery. So through like the collaboration between our department and Tanzania, so it's great to have her in the team. We also have David Dustin, who's like the lead engineer in the project. David brings 20 years of experience in mechanical design, and his expertise in magnet actuation has been like instrumental to the success of this project. And Clark Monroe, who's like an electrical engineer who's just joined our team, and both David and Clark work for Function Engineering, providing the logistic and technical support for the medical device development. And of course, we have Donna Rounds and Iris Bike as part of the CTL team. So just an introduction about the problem that we are dealing with. So a normal human skull is made of like several cranial bones connected together with multiple cranial sutures. Normally, these sutures are open through the early life to just allow the brain to grow normally, but in some cases, one or more of these cranial sutures fuse earlier than expected, and that leads to one of the deformities that you see here. Also, in the much more complex cases, which we call it syndromic craniosynostosis, usually patients develop what's called elevated intracranial pressure, and that could lead to severe neurodevelopmental abnormalities. So one of the surgical approaches that we perform for these kids is called cranial distraction osteogenesis using this titanium distractor. The goal of the surgery is to simply initiate the gradual expansion of the skull in the right direction to restore the normal shape of the skull and to normalize the high intracranial pressure. So in order for us to do that, each distractor has an external activation port that comes out through the scalp, and then you use like a small screwdriver to initiate the distraction around 1 to 2 millimeters per day. But the problem with this is, as you could imagine, like having like metal rods extending out of the skull of like a kid or even like a baby is definitely problematic for different reasons. Beyond like the psychological burden for the families and for the kids themselves, also like it's a very stressful when it comes to like social events and normal physical activity on the daily basis. Also, it has a risk of mechanical failure. So in the second image here, you can see like that the external activation port is broken, and the surgeon here is trying to improvise and use a needle holder to keep the distraction going. But unfortunately, in such cases, mechanical failure is inevitable. In the more serious complications like wound infection and skin necrosis and wound breakdown, this could be very serious and could be fatal. In some cases, I was unfortunate actually to see this myself. Like during my residency, I had an 11-month-old baby girl who was a perfect candidate for this procedure. 6 days after surgery, she developed serious infection and went on to develop brain abscess. And unfortunately, after 2 weeks in the ICU, she passed away. So even in very like high income countries and like well-established settings for healthcare, the complication rates are still very high, up to 25%. And 1/3 of these patients require another surgical intervention just to deal with the complications. So since we now like have established like the fact that the external activation ports could be very problematic and cause a lot of complications for this young population, so the question is how to address these complications and minimize the risk of such complications. So the answer for us was to remove the external activation port and replace them by a fully internalized, non-invasive, contactless magnetic actuation system. And the way the device should work, we have here in the implanted part of the device, we have an internal magnet mounted to a two-stage gearbox, which can translate the input torque generated by the external magnet and the handheld driver to develop like and to generate the axial force needed for the distraction. So the way it works, when you approach the internal magnet by the handheld driver, both magnets coupled through the skin, and then you turn the knob of the handheld driver, pretty much like a pepper grinder or something, to initiate the distraction. We had the first prototype that for like this design, and we tested it on cadavers. And the goal of the cadaver study was one, to make sure that the device could be working well and reliably, to initiate the distraction in a way that could be incremental in steps and in small steps, and it can be reliable. And the second goal was to ensure that the device can maintain in place, can stay stable, stay in place, and maintain the achieved distraction over time. Thankfully, like the cadaveric study was a very successful study, and we achieved both goals. So from a market standpoint, there is a huge potential here, because every year we have more than 200K newborns suffer from craniofacial abnormalities, including craniosynostosis. And one of the good things about the MAC is its strength, its versatility, and the dynamic force profile that make it suitable to be used on any kind of craniofacial abnormalities across the craniofacial skeleton. Also, it can be adopted in other specialties like orthopedics and spine deformities, because initially, 30 years ago, the way we started to do craniofacial distraction was by adopting the technology and the technique from orthopedics. So I think it's very ironic that after all these years, we're kind of returning the favor to them, but with a better solution and fewer complications. So the market of craniofacial distraction systems in the US is projected to exceed $1 billion, and globally it's about $350 million. And you may ask why there is the global market is way less the market in the US. And we believe that the high rate of infection, especially in low middle income countries, could be the driver for this small revenue. Therefore, we think that by eliminating the source of infection, which is the external activation port, that would lead to a huge expansion of the market globally and also in the US, plus the adoption of this technique in other specialties like orthopedics and spine. So I started working on this idea back in 2019 when it was just an idea, and it took me a while to get it up and running, but it wasn't till 2023 when I joined the department here at Weill Cornell and worked with our colleagues in the VME school up in Ithaca with Dr. Newton DeFerria and his MEng program, when we started working on the theoretical modeling and the initial mechanical concept. And in 2024, I was lucky to receive the Daedalus Fund for Innovation Award. And that was a huge turn point for me, because we were able to recruit experts like David Dostal in magnet actuation, and also execute all the testing, like the benchtop testing and the mechanical testing, all up to the prototyping, and then the successful cadaver study that you just saw earlier. So right now we are awaiting the approval for the animal study to move on and continue working on the and executing the next milestones for us. Therefore, we're just looking for more collaborations with business partners, with marketing experts and regulatory consultants. And also we are seeking $1 million in funding to execute the next milestones we should have until hopefully we can start the first in-human clinical trial by the summer of 2027. Just one final note I would like to leave you with is I may have seen the worst of this intervention, losing a patient to a corrective surgery wasn't a pleasant experience. So the MAC for me is all about making sure that the neurosurgical intervention, which is supposed to be life-saving, never becomes a life-ending one. Especially for a very young population here in the US and globally. Thank you very much for having me, and please feel free to reach out if you have any questions.
Can I ask a question? I hate to ask in a case like this for a pediatric device, which is so promising, but what is the payment strategy for this procedure right now?
I'm sorry, I couldn't hear you. What strategy?
The payment.
The payment?
Yeah, reimbursement payment strategy, or how is it? Yeah.
We are not there yet. We haven't thought about it. For the current distraction system that we use currently, it is covered by insurance, I believe. So it's not something that patients pay for it or something. But we haven't thought that far yet.
Thank you.